I'd like to ask a little bit about T-DM1 in the adjuvant neoadjuvant setting. I think it's a drug that we had a lot of hopes for based on its second-line metastatic data that we'll talk about briefly in a few minutes. But I think in the first-line setting and in the adjuvant neoadjuvant setting, I don't think it's lived up to expectations. Let's start with hope. You know, you guys did the I-SPY trial of T-DM1 and pertuzumab. Where do you think this is going, T-DM1?
Well, it's actually really interesting. I mean, there's I think 3 different data sets, and you have to sort of look at them in relationship to Marianne, the first-line metastatic trial. It appears that adding pertuzumab to T-DM1 doesn't necessarily help. We saw that in Marianne, where T-DM1 pertuzumab, and the trastuzumab taxane arms were all similar in terms of PFS. In the neoadjuvant setting, T-DM1 and pertuzumab was inferior to so-called TCHP, the standard regimen of taxane, carboplatin, and the double antibodies in the Christine trial. In our study in I-SPY, which is an adaptively randomized design, so you look at estimated pathologic PCRs, the T-DM1 plus pertuzumab followed by an anthracycline arm was superior to a taxane plus trastuzumab followed by an anthracycline arm. That may be because we gave double antibodies as opposed to a single antibody. It's not clear. But I do think that T-DM1 plus pertuzumab combination will not be pursued. But T-DM1 itself may be quite good, because we saw in the ADAPT HER2 trial that T-DM1 by itself, you didn't even have to add the endocrine therapy, resulted in a 40% path CR rate if you just gave 4 doses to ER-positive, HER2-positive breast cancer, which I thought was very impressive. So it's certainly not dead, and we have the ATTEMPT trial, which is nearing completion, actually, maybe at the end of this
week,
month.
Actually next week.
Oh yeah, I knew it was October.
I got the message, actually.
And we are both participating in that trial, which randomizes 3-to-1 to a year of T-DM1 versus the APT, so-called regimen, 12 weeks of paclitaxel and a year of trastuzumab. I still remain sort of up in air about this, because I think a year of every 3-week T-DM1 may be harder for many patients than the APT regimen.
So let me ask you a question from our European colleagues about ATTEMPT and about using a taxane trastuzumab for 12 weeks as therapy for early stage breast cancer. Is that used in Europe? Michael, do you use it?
Can I start?
Yeah, please.
I mean, number one, the Tolani data, which have been published, I think, last year.
About a year and a half ago, yeah.
Are reassuring us that there is a patient population like the node negatives with small tumor burden, small tumors, maybe the patients older than 60 and so on, who still are HER2 positive, still need chemotherapy and trastuzumab, but maybe with additional cardiac risks or obesity or diabetes and so on. Those are the patients in which, when we talk with them, we think, well, we don't like to give them the full dose and the full anthracycline cycles and so on. So this data are very reassuring that we have an excellent disease-free overall survival by 12 weeks of paclitaxel, weekly paclitaxel, with the addition of trastuzumab. So actually, we entered this type of therapy in our national guideline in the year 2016. So we do it, we use it.
Russell, same thing?
Exactly the same.
Okay. So let's